My name is Professor Stephen Atkin. I'm Head of Postgraduate Studies and Research here at RCSI Bahrain. I want to talk to you about global epidemiology and challenges of obesity. So the agenda today is we'll talk an introduction and definition, what the global prevalence of obesity is, the prevalence of obesity here in Bahrain, the medical consequences of obesity, and obesity-related comorbidities. So obesity is a global public health problem that has spread to other developing nations. The worldwide burden is estimated to be 1.5 billion overweight and 700 million obese individuals, and overweight and obesity constitute a fifth leading risk for global deaths. Looking at it globally, a high BMI, that's a BMI over 25, accounted for 4 million deaths globally, nearly 40% of which occurred in patients who had a body mass index between 26 and 29. So the definition classification of obesity is shown here. Normal weight is 18.5 to less than 25, and this is defined as the body mass index, which is weight in kilograms over height in meters squared. And overall obesity is defined as an abnormal or excessive fat accumulation that may impair health. Now, that's an important definition, and the reason is because, as you can see here, obesity is defined as having a body mass index over 30, with obesity class 1 at between over 30 but less than 35, obesity class 2 being greater than 35 and less than 40, and obesity class 3 being more than 40. However, you have to look carefully at the individual that you're applying this to. So, for example, the English rugby team have got a body mass index well over 30, but one wouldn't want to call them fat in any way, shape or form. So we'll look at a study that looked at the trends in body mass index in 200 countries from 1975 to 2014. And this was an analysis of 1,698 population-based studies involving 19.2 million participants. And what it actually showed was, as you can see here in the top left, that men with a body mass index of 30 to 35, as time progressed, then there's a marked increase in the amount of obesity. And if one looks specifically here in the dark green, which is the Middle East, you can see that the Middle East follows the same trend as all the other countries that were sampled in the increase of obesity. And this was also reflected in that seen in women with a body mass index of 30 to 35, and also men with a body mass index greater than 35, and women with a body mass index greater than 35. As you can see, as time is progressing, then there's a marked increase in the amount of obesity over time. Turning now to a study that was published in the New England Journal of Medicine, looking at the health effects of overweight and obesity in 195 countries over 25 years, that analysed data from 68.5 million persons for the trends and prevalence of overweight and obesity among children and adults between 1980 and 2015. You can see that the global prevalence in obesity was increasing both in males over the time period as well as in females over the time period, which is in accord with the previous study that we discussed. Looking at the age standardized prevalence of obesity in 2015 in men on the left and women in the right, what you can see is that the developed countries such as America have a marked increase in the amount of obesity, and also that is also seen in the Middle East population, whereas in European countries, for other first world countries, then you can see that the prevalence of obesity varies quite markedly between 25 and 35%. Looking at the gender distribution, you can see that obesity is more marked in females in comparison to males. And as one may expect, those living in an urban population, the prevalence of obesity is greater than those in a rural population, where you might expect people are going to be walking more and having more manual work. But as you can see, that the actual difference between urban and rural populations are relatively modest. If one then looks at the prevalence with respect to the age decades, what you can see is that as you get older, then the overall obesity prevalence increases and has peaked at around about between the ages of 55 and 64. And then there is a decrease in the prevalence of obesity. Now, this reflects the fact that the older population probably was at a time when obesity was less, than eating habits were different, and the fact that as you get older, as we shall see shortly, that obesity is associated with increased mortality, and patients may have died, therefore giving a false impression of lower rate of obesity in this population. But if we look specifically now at the prevalence of obesity in Bahrain, what we can see is that for boys aged less than 20, then those who are overweight and obese are around about 22.4%, and those who are obese, 9%. Whereas when one looks at girls, the same age group, less than 20 years, 26.7% of girls were overweight and 10.7% were obese. If one then looks at men over the ages of 20 years of age, you can see there's a marked increase with those who are overweight and obese at 67.7% of Bahraini men. It accounts for 31% of whom are obese, and for women 75% were overweight and obese, with nearly 43% were genuinely obese, which are huge figures. What is clear is obesity is now recognized as a disease and a health issue. And looking at the American organizations and regulatory bodies, it's thought to be a relapsing chronic disease that needs to be treated, that has got a morbidity and mortality associated with it, according to the American Association of Clinical Endocrinologists, the US Food and Drug Administration, the American Medical Association, and the Obesity Society. Looking at global organizations and major regulatory bodies, the World Health Organization, the European Medicines Agency, the World Obesity Federation, and the European Association for the Study of Obesity all agree that obesity is a recognized chronic clinical condition. There's association of genetic, metabolic, and environmental and behavioral factors, which has got an association with both increased morbidity and mortality. However, what has become abundantly clear is that the central regulation of appetite and energy homeostasis is a very complex situation. And I'm not going to go into detail here, but it is a combination of the brain, of sensations, the pancreas, the gut, and the stomach, all of which are producing a myriad of different protein regulatory factors. In the past, obesity was looked at fairly simply. You had energy intake and you had energy expenditure, and if your energy intake was greater than energy expenditure, you put on weight. But what is increasingly evident is that energy intake is complex, depending on palatability of food, the pleasure of food, the feel of food, the smell of food, and the environment can impact quite markedly on energy expenditure through inactivity, smoking cessation, and psychosocial factors. And then in addition to that, you've got other body functions which are imposing themselves on the hypothalamic to regulate weight, such as if you're on some medications, some antidepressant medications are associated with marked weight gain. We know that genetics has got a major input in how easily or not people put on weight. It's now increasingly evident that the gut microbiome is important for weight gain, as well as how adipose tissue affects weight and also the response of the pancreas. The question then is, does it matter? And the answer is really shown here in part, which is a Kaplan-Meier curve. And if you look at that in the brown, which is the normal BMI, and what you're seeing is the proportion of people who are alive here on the y-axis, and on the x-axis you're looking at age. And if one looks at the age of 70, if you have a normal BMI, you have almost an 80% chance of reaching the age of 70. If you look here in the light blue, then what you can see is if your BMI is between 35 and 40, you've got around about a 60% chance of reaching the age of 70. Whereas if you've got a BMI of 40 or 50, so you're morbidly obese, then in fact your chance of actually reaching 70 is only around about 50%. So there's a marked decrease in your life expectancy as your weight goes up. And this is shown here. Everyone looks at the global deaths associated with a high BMI. On the left, we've got the curves for deaths in 1990 versus on the right, the deaths in 2019. And the deaths are in millions. And on the x-axis for both graphs, you can see the body mass index and what people are dying of: cardiovascular disease, cancer, chronic kidney disease, and diabetes. And what's evident is that the proportion of deaths for any given disease is unchanged between 1990 and 2015, with the same amount of people dying of cardiovascular disease, but same proportion of cancers, chronic kidney disease and diabetes. But what is clearly evident is that the number of deaths has increased quite dramatically for any given body mass index, indicating that there are other factors associated with this morbidity and mortality seen with obesity. And obesity is associated with multiple comorbidities. So just one looks at the metabolic factor. We've got an increase in asthma, non-alcoholic fatty liver disease, gallstones, infertility and cancers, and an increase in cardiovascular disease, which encompasses stroke, dyslipidemia, hypertension, coronary artery disease, coronary heart disease, and pulmonary embolism, together with type 2 diabetes, prediabetes, thrombosis and gout. And of course, as you put on more weight, then there are mechanical factors which then add. So the increased weight that you put on will affect your breathing and sleep apnea, chronic back pain, increased incontinence, and reduced physical functioning and decreased well-being, as seen by the increase in depression and anxiety associated with obesity. And what has been seen now is that the prevalence of obesity-related comorbidities generally is increasing as your weight increases. So, for example, shown here in the brown is if you are normal weight, and then as you increase your BMI to the dark blue, which is a BMI of over 40, you can see that generally, as your BMI increases, then the risk of that morbidity also increases. So that's seen for coronary heart disease, hypertension, where you can see almost a straight line as you increase your BMI, and type 2 diabetes. Interestingly, for dyslipidemia, what you can actually see is that as soon as you become overweight, then your abnormal blood lipids increase and then are maintained, that don't change as your BMI goes up. So there you can see why perhaps being overweight is a cardiovascular risk in its own way. So if one looks then at the prevalence of obesity again with BMI, you can see that there's an increase in gallbladder disease, osteoarthritis, sleep apnea, and non-alcoholic fatty liver disease as well. And essentially, if you look at the kind of male-female ratio, what you can actually see is there's an increase, first of all, in all of these conditions, be it type 2 diabetes, heart disease, hypertension, stroke, osteoarthritis, and the like. But you can see that the gender, there's an imbalance. So, for example, for though women are more affected by an increase in type 2 diabetes than men, though both are increased, whereas, for example, men, there's an increase in osteoarthritis in comparison to women. But what we do know is that obesity is driving the type 2 diabetes pandemic. And what you can see on the top is a map of the United States, and it's been mapped for obesity from 1994, 2000 and 2010. 2016 is different because it was looked at in a different way, so we'll only concentrate on 1994, 2000 and 2010. And what you can see is this heat map. So as you increase to 2000, you can see there's an increase in blue and dark blue, which corresponds to a marked increase in obesity. And when you get to red, that means that more than 26% of the population are obese in those areas. But what you can actually see is that heat map is reflected in diabetes. So you can see that the prevalence of diabetes increases in 2000, then markedly increases in 2010, following the epidemic of obesity. So when one looks at the risk of developing type 2 diabetes, then if you are obese, you've got a 5 times increased risk of developing type 2 diabetes in comparison to a healthy subject. If you've got impaired glucose regulation, that's impaired glucose tolerance, that's impaired fasting glucose, prediabetes in America, then there's around about nearly a 7% increase, or 7-fold increase in impaired glucose regulation for the development of type 2 diabetes. But if you've got a combination of obesity and this impaired glucose regulation, you can see you've got a 17-fold increase in the risk of developing type 2 diabetes. And the risk of developing type 2 diabetes, as you can see, increases markedly as your weight goes up, with it starting to increase really when you're overweight, and then almost a straight line up to a body mass index of 35, then a marked increase as soon as your BMI goes over 35. So therefore, if you've got a BMI of between 33 and 35, you have got a relative increased risk of 54 in comparison to those normal weight individuals. So then looks at the prevalence of prediabetes and diabetes, looking at the different measures of how this is done. Now you can diagnose diabetes by the glycated hemoglobin, by fasting plasma glucose, or 2 hours plasma glucose following a glucose tolerance test. And basically what you can see is that irrespective of the measure, there is an increase in the proportion of individuals who actually develop either prediabetes or diabetes. And what is abundantly evident is that cardiovascular disease is the primary cause of death in those people who are obese and with type 2 diabetes. And what you can see here, this is what I call a forest plot. And on the right of the line, which is the dotted line here, which is 1, then there's an increase in death. To the left of that line, there's a decrease in death. And what you can see is that if you are healthy weight, body mass index 18.5 to less than 25, then you are on that line of 1. But as soon as you become overweight, then you can see there's an increase in cardiovascular death, marked increase in type 1 obesity class 1, and even further so in obesity class 2. And what's also increasingly evident is that cancer and obesity are hand in hand, and specifically certain cancers such as esophageal adenocarcinoma and the cancer of the endometrium. Esophageal adenocarcinoma probably because of the reflux, the acid reflux. If you've got obesity and hiatus hernia, and that can predispose to increased esophageal carcinoma. In endometrium in women, because there's an increased conversion of testosterone to estrogen in the fat tissue that can then directly affect the endometrium. We know that obesity and the abnormal lipids affect the liver with non-alcoholic fatty liver disease that can progress to cirrhosis and liver cancer. And also, if you look at the amount of weight gain that you have and the development of the symptoms of sleep apnea, what you can see is that if you have a modest or no sleep weight gain, there's very little change in the symptoms of your sleep apnea. But if you put on 5 to 9% of body weight, then your symptoms, if you have sleep apnea, will double. And if you then put on further weight, you can see that the mean change in the measure of sleep apnea increases dramatically. And we know that obstructive sleep apnea is associated with enhanced cardiovascular disease with increased mortality. And what we also know is that as you increase your weight, then your well-being and your feeling of impaired physical function also go down. This is looking at the SF36, which measures quality of life. And what you can actually see is as your BMI increases, then your quality of life decreases. However, if you lose weight, then you can improve these obesity-related comorbidities. So if you lose between 5% and 10% body weight, then there's a marked reduction in risk of type 2 diabetes. There's a marked reduction in cardiovascular mortality. There's a marked improvement in your blood lipid profile. There's a marked improvement in your blood pressure. There's a marked improvement in the severity of obstructive sleep apnea. And there's a marked improvement in overall health-related quality of life. Put it another way, if you look at the reduction in BMI causing a reduction in obesity-related comorbidities, so if you lose 5% reduction in your body weight, and this is estimated in the United States, then you reduce 3.6 million cases of hypertension, 1/3 cases of cancer, 3 million cases of coronary heart disease and strokes will be reduced, and there will be a reduction of 4.1 million cases of type 2 diabetes and 1.9 million cases of osteoarthritis. And overall, by that reduction in 5% in body mass index, the overall potential cumulative savings to the health system in the United States is $229 billion. Huge reduction that would benefit the healthcare system. So in conclusion, obesity is a chronic disease that is increasing in prevalence. The etiology of obesity is complex, multifactorial, influenced by genetics and other obesogenic environmental factors. A reduction of weight of 5 to 10% may improve obesity-related comorbidities of a reduction in type 2 diabetes, reduction in hypertension, a reduction in the abnormal fats in the blood, a reduction in specific cancers, a reduction in obstructive sleep apnea, better quality of sleep, and an improvement in overall physical function. Thank you for your attention.